morning everybody. Today topic of discussion is combination therapy in hypertensive patients. So we all know that hypertension is a huge burden in the population, as much as close to 50% of the general population are being affected with hypertension, and we'll just review a few words and discuss something about combination therapy, which is now being accepted in the guidelines to be used as upfront combination therapy in patients with hypertension. So you all know that the hypertension is again categorized as slightly elevated blood pressure, where the systolic blood pressure is 120 to 129 and the diastolic is less than 80. So here these patients are at risk to progress and lifestyle changes are advised. Then there comes a stage 1 hypertension, when the blood pressure is 130 to 139 and the diastolic blood pressure is 80 to 89. So here, depending on the risk factors that the patient has associated with the blood pressure, we advise them lifestyle modification, and if necessary they can go on to have some medications also if required. And then comes the stage 2 of high blood pressure, where blood pressure readings are 140 or greater and the diastolic blood pressure is 90 or higher. Here is this group of the patients which require medications apart from the lifestyle intervention. And then there is a category of patients where the blood pressure is greater than 180 and the diastolic blood pressure is 120. So this comes in the category of hypertensive crisis. So what are the benefits of achieving the target goal of the blood pressure, which is in general population it is 130 by 80, is that hypertension is a major risk factor for stroke or a heart attack or a heart failure. So if you, or rather if we in a general population achieve the target or goal blood pressure, we can reduce the incidence of stroke by as much as 40%, reduce the incidence of heart attack by as much as 25%, and reduce heart failure by as much as 50%. So we know that treating hypertensive patients to the goal is very important. And then again, this is a chart, it may seem a little bit complex, however it is just dividing our hypertensive populations according to the risk factors that the person has. So if a hypertensive patient, depending whether he is in grade 1 or grade 2 or grade 3, what the risk factors does the patient has? Does the patient has dyslipidemia, associated diabetes, obesity and other cardiovascular risk factors? If it is associated, and this table is then divided and looked into whether your patient falls into low risk, moderate risk and high risk. And you also have to look whether the hypertensive patients has any end organ damage, that is, has it involved the retina, has it involved your kidneys, and accordingly you are going to stage your hypertensive patients into uncomplicated or asymptomatic or an established disease, and you are going to treat him accordingly to what stages does he fell into. So we'll talk now on the combination therapy. So why do you need a combination therapy in our hypertensive patients right from the beginning is what we are going to discuss today. So the majority of the hypertensive patients, they actually need a combination therapy. They need 2 or more drugs to achieve the target blood pressure control, and this was what was found in multiple trials, where there was these are all large trials of hypertensive patients. And you can clearly see that all the trials, they eventually require more than one drug to achieve the target blood pressure in their patients. So 2 drug combination therapy will require in controlling the blood pressure in almost 2/3 of the population of hypertensive. So actually it's more of a requirement rather than why to start upfront, and it has been seen that combination therapies are very effective as compared to monotherapy. So if you are starting on a monotherapy and you just double the dose of that monotherapy, and rather than that, if you just add on another class of drug which is complementary to that class of drug on which you have started the therapy, it is shown that it is almost 2.5 to 5 times more effective if you add on another class of agent rather than just doubling the dose of the drug which you have started. So it's absolutely effective therapy rather than the monotherapy which has been used in for years. That's why combination therapy is more effective. Lower doses of the drugs are required, and combining them upfront is effective. Another important point to be mentioned is adherence. When you are combining the two therapies in a single pill, obviously the requirement of the agents or the molecules is reduced, and it has been shown that you can significantly improve the non-adherence rate by up to 25%. So this combination therapy, as I have mentioned, that they are complementary to each other, that is, these have different class of action. So there is thiazide diuretics, then there are angiotensin receptor blockers, then there are calcium channel blockers and ACE inhibitors. So these are the four class of drugs which are used upfront in our hypertensive patients. Then there are beta blockers and other agents which are generally used if these agents are, apart from these agents, are not used, or if the upfront these four drugs are because of some side effects or they are unable to use these drugs. So if you see the green dotted lines, it is clearly showed that you can combine these therapies. You can combine calcium channel blockers with an angiotensin receptor blockers, you can combine the thiazide diuretics with an ARB, you can combine an ACE inhibitor with a thiazide diuretic. And whenever you are seeing the dotted lines, these are the patients which is the combination therapy which is possible, however it is not preferred, so to say. And a note here to mention is that angiotensin receptor blockers should not be combined with an ACE inhibitor, and it is not recommended, and that is why you see a red colored arrow there. So what is this complementary mechanism of action that I just discussed? If you see calcium channel blockers, how they act by arteriolar dilatation, and this causes peripheral edema. They are less effective in low renin patients, and they have a side effect in terms that they activate the RAS. Alright, so to counteract this we have an ARB. So what does ARB do? It attenuates the peripheral edema which was a side effect of the calcium channel blocker, and they are effective in high renin patient, and they are very effective in patients with cardiac ischemia also. And this, combining these two agents will cause a synergistic blood pressure reduction and with a complementary clinical benefits. So another rationale of combining diuretic with a ACE or a beta blocker is that diuretics, if used in alone, there is results in a relative volume depletion, and this activates the RAS and to a lesser extent the sympathetic pathways. So what do? You add on an ACE inhibitor or an ARB to block the RAS and a beta blocker to counteract the sympathetic nervous activation. So in this way, these two molecules, when combined together, they act in a complementary manner. Again, apart from what we have discussed, whenever you give an initial combination therapy, the blood pressure reduction is achieved much faster as compared to the drugs when we start on the monotherapy. So to add on some of the advantages, as I have already discussed, that combining a calcium channel blocker or a thiazide diuretic which activates RAS can be counteracted by combining with an ACE or an ARB. Again, this combination will limit the potential adverse effects, those associated with a diuretic or a calcium channel blocker monotherapy. They reduce the risk of hypokalemia because of diuretics when you are combining a diuretic with an ACE inhibitor, and overall the prevalence of peripheral edema because of calcium channel blockers are also reduced. So this combination therapy, they ensure that RAS is also inhibited, because many of your patients are having diabetes, proteinuria, left ventricular hypertrophy. So there you do require RAS inhibition, as it has been benefited and it has been found to reduce the LVH and proteinuria, especially in diabetic population. So these patients require RAS inhibition as a part of the therapy to counteract this proteinuria and LVH. So combination therapy can help in that way also. So where all to use beta blockers? So beta blockers are once again in the guidelines for hypertensive. They should be used whenever there is a specific indications. For example, the patient is having angina, patient requires heart rate control, a post myocardial infarction, a patient with chronic heart failure with reduced ejection fraction, and also as an alternative to ACE inhibitors in younger hypertensive women who are planning pregnancy, as ACE inhibitors are contraindicated in women who are planning pregnancy. So to say that combination therapy is a practical necessity rather than why to use it. So it's a practical necessity now that you start your patients of hypertensive on a combination therapy. So it's required in about 75% of the hypertensives to achieve their target blood pressure. It has greater efficacy, there is faster achievement of target blood pressure, there is higher response rate. It may make therapy effective in a broader population also, and additive anti-hypertensive effects are seen with the complementary pharmacological mechanism, and definitely it improves the side effect profile in your patient. So combination therapy can be given in a fixed dose combination in a single pill. So it makes it more effective, it improves the compliance. However, and it can also reduce the cost and the pill burden to the patients also. However, a disadvantage which I may mention is that if other patient has contraindication to either one of the agents in that fixed pill, so you cannot use that fixed pill, and in a case any adverse event do happen with these fixed dose pills, you may not be clear which medicine has caused that adverse event. So these are a few minor disadvantages, so to say. So if you basically compare the different strategies to manage your hypertensive patient, when you compare low dose monotherapy, then you put on your high dose monotherapy, then go for the combination therapy, and either use an upfront single pill combination therapy. So this single pill combination therapy, we have already discussed, it is its efficacy wise it's much more potent. The time to reach blood pressure control is much faster, there is lesser blood pressure variability, it's more simple, it's flexible, the compliance is lot better, and the tolerability is lot better. Now just to discuss a few compelling indications that where all which antihypertensive agents to be used. So in a patients where you have hypertension along with heart failure with reduced ejection fraction, you can use ACE, ARB, beta blockers, diuretics, or an aldosterone antagonist. Then you have a post myocardial infarction patient, then again you have to use an ACE, ARB, beta blocker and an aldosterone antagonist. Then you have a proteinuric CKD where ACE inhibitors and ARBs are used. A patient on angina, beta blockers, calcium channel blockers are preferred. AFib or atrial flutter, you can use beta blockers or a non-dihydropyridine calcium channel blocker. Now there are some other effects, like a patient having comorbid condition, a patient with benign prostatic hyperplasia, where you can use alpha blockers, then it can also act as an antihypertensive agent. Then the patient with essential tremor, quite common in general population, beta blockers, they can act both, they can act as a antihypertensive and act as a drug for essential hypertension. A patient with hyperthyroid, a patient with migraine, there also you can use beta blockers. A osteoporosis patient, thiazide diuretic can be helpful. Patients with Raynaud's, dihydropyridine calcium channel blockers are effective in controlling both Raynaud's and hypertensive. So these are some of the therapies where you can use a drug which helps both the ways. And on the flip side, there is also contraindications to the drugs. Diuretics like chlorthalidone, they are contraindicated in patients with gout, and there is relative contraindication in patients with glucose intolerance or metabolic syndrome, or a patient with hypokalemia and in pregnancy. Beta blockers are contraindicated with asthma or the patient is having bradycardia. Again, they may also cause some glucose intolerance, however it's not an absolute contraindication there. Again, calcium channel blockers, they are contraindicated in heart blocks, they are contraindicated in very severe left ventricular ejection fraction. And ACE inhibitors, as I already mentioned, they are contraindicated in pregnancies. If they having a previous angionuretic edema because of ACE inhibitor, they are not used in patients with hyperkalemia and a bilateral renal artery stenosis. So what does the guideline now say? So guideline now say a single pill combination therapy, either ACE/AR combining with a calcium channel blocker or a diuretic. And if the patient is not controlled on this combination therapy, you can go forward with the combining all these three drugs together in a single pill. And if it is not helpful, then the triple combination can be used along with the fourth agent, either spironolactone, or you can use an alpha blocker or a beta blocker as the case suggests. So just a quick talk about triple drug combination therapy. It's only used when your patients are uncontrolled blood pressure with the two agents. You have to look that the patient's compliance is, patient is adherent to the drugs, and they help to overcome the clinician's inertia, so to say, and they act as a more potent antihypertensive formulation in a single pill. So fixed dose combination therapy, they are convenient to the patients, they have low cost, low side effects, and they are overall better in terms of giving therapy to your hypertensive patients as compared to just monotherapy. And this fixed dose combination, they actually, every component of your hypertension is controlled with this fixed dose combination therapy. It's quite simple and low pill burden and has better compliance rate. Thank you very much.